like to thank you so much for joining us. This is Worldview Wellness, Health Matters, Episode 5. I'm Ty.
Number 5.
Number 5.
Nice round number.
And who are you?
Oh, I'm Micah.
Hi, Micah.
Thanks for joining us.
Yeah, thanks for joining us. Today we're going to be talking about cholesterol. We did mention it at the end of our podcast episode number 4.
That's right. Cholesterol and statins.
Yeah. So let's dive into the history. I'm pretty much going to let you take it away because you are the medicine man with all the information.
Well, I try to have a lot of information. Maybe not all of it. Then I wouldn't be able to grow anymore.
I like the way that you said that.
So, ultimately, what I really want to kind of get started with today is just, what is the deal with cholesterol?
And why? Exactly. Yeah. Why are so many Americans being pushed into taking this medication? What are its benefits and what are its risks?
Yeah, so we're going to talk about that. So how I want to start off is by exploring this concept that really is behind a huge amount of nutritional advice, and also it's a huge push behind the pharmaceutical industry as well, and just in medicine in general. And so that is a hypothesis called the cholesterol hypothesis. And so the cholesterol hypothesis is basically the reason why, if you are alive and listening to this podcast, chances are you fall into the demographic where you have probably heard something about low-fat diet or cholesterol related to heart disease or stroke or something like that, probably just about every single day of your life.
Yeah.
Because the push to get people to fall in line with that narrative has essentially been going on since the mid-1950s, when President Eisenhower had his heart attack while he was in office, and Ancel Keys was then brought in to start talking about how fat was the cause of all of the heart disease that we had in this country. So while this is, seen more as, I guess in the science and in the medicine, something that's just kind of been more recent within the last 100 years, or at least since 1955 or so. That this, some of the history behind this kind of goes back another 100 years to 1856, where Rudolf Virchow, basically in doing autopsies and that type of thing, described atherosclerotic plaques and was able to find cholesterol deposits in those atherosclerotic plaques. So he was able to see that cholesterol was in the plaques, but he wasn't able to make any kind of causative claim there. It was just that there seemed to be a correlation with cholesterol and atherosclerosis. And then fast forward a few decades to 1913, and Nikolai Anichkov did some famous experiments on rabbits. He made the hypothesis that he thought that if he were to feed rabbits a diet high in cholesterol, that they would develop atherosclerotic plaques. And sure enough, he fed rabbits in 1913 egg yolks, and was able to show that in those rabbits, when they were fed the egg yolks on a consistent basis, they did develop atherosclerotic plaques. However, there was one glaring problem with that study.
Rabbits don't eat eggs.
Rabbits do not eat eggs.
Yep.
Maybe Cadbury eggs.
Maybe.
But
yum,
they
yum.
do not eat eggs. So, rabbits are herbivores, and so basically they were able to show that in that population that atherosclerosis could be brought on by that, but any subsequent studies done with carnivores or omnivores failed to reproduce that study. So that's actually a good example of kind of more in the modern science how financial interests can certainly skew a study if they're looking for a particular outcome, and so you can manipulate the study and you can manipulate the statistics to get it to say what you want it to say, but that's not necessarily replicable. And that's, a big, huge problem in science today. So moving along, 1948, this was, this is big. If you talk to cardiologists or general practitioners or just about anybody in medicine, there was a study in 1948 up in the Boston area called the Framingham study, and that started in 1948. And the assumption of that study was that cholesterol was a risk factor for myocardial infarction, which is heart attack, based on the fact that it was observed that cholesterol levels were slightly increased following heart attacks in previously healthy men. That was a huge, huge study that came out, and that was another thing that kind of led to the recommendations of the low-fat diet and cholesterol-lowering drugs and all of those things. And it was kind of, just widely accepted, and it wasn't really debated all that much. 30 years later, there was a follow-up study that was done that basically revealed that high cholesterol was not a risk factor for men older than 47 and not for women at all. So now part of the study did find that if you were, I think it was between the ages of 20 and 47 or 25 and 47, something like that, that higher levels of cholesterol in that demographic could potentially be correlated with with the development of cardiovascular disease later in life. But, once you got to 47, that didn't seem to be true anymore. And so, and then, of course, not for women at all. So then we fast forward just a few years to that, and then we get into the Ancel Keys data. So this is in 1953. Ancel Keys publishes his study that was named the 7 Countries Study. And this study revealed a correlation between a high-fat, high cholesterol intake in the diet and cardiovascular disease. It was a very convincing study initially, but there was a huge glaring problem with it. That is another kind of example of how some of these, how some of this science and the studies can be manipulated. So, although everybody knows this, science as the 7 Countries study, it was actually done on 22 countries. And so 15 of the countries that were originally in the data were thrown out. And so the remaining 7 countries, there was a very high correlation with, fat and cholesterol in the diet and cardiovascular disease. So, the corruption of that study comes in when you look at the fact that, if you put those 15 countries that were omitted into the study, all those correlations disappear. It just turns into noise, and there's no real clear signal that high-fat cholesterol intake is in any way correlated to cardiovascular disease. So that was a huge study, and that's really kind of where that's where we get the basis for statin therapy and for the recommendations of a low-fat diet, which is not our historic diet.
Right. I find that to be so wicked. It's so wicked to skew studies in that way.
Yeah.
And even back then, they didn't have the resources that we have now. So
Right.
there's no way they could find any evidence to contradict this study that Ancel Keys put out. They didn't have the resources available to every common man.
Well, and strangely enough, that still seems to be the case. In doing my research for this podcast, I was trying to go back, and we'll cover this data later, but I was trying to go back and find, hey, what, maybe back in the early 1900s, what was the average cholesterol level of normal, healthy Americans. And I was actually able to find a study, but it was behind a paywall, and I had to reach out to my network of other doctors, physicians, medical providers that have institutional access or their own paid access. Otherwise, I would have had to pay $25, or I think it was $26 to have access to that data from a study that took place in 1950.
Most people wouldn't even know where to look. Most people
Right.
don't have that kind of access to PubMed
Well,
or to medical documents and things like that.
and a study that's that old, there should be, some reference to some of the studies that are that old, as far as just what anybody could pull up online on the internet.
Well, as far as I'm
But
concerned,
but the internet, if you go back and you type in, and I would challenge anybody out there to do this, and if you can find a resource, let me know.
Yeah.
But if you go online and you type in historic cholesterol numbers or historic cholesterol reference ranges or anything like that, so that you can find out what the historic levels of cholesterol were in a population, it's impossible to find anything past about 1980.
what I was going to say earlier was that I think that science should be absolutely transparent. I think that it should be openly sourced so that the common man, that anybody can find the research that is readily available on the internet, and it is made almost impossible and really difficult, so people give up before they ever even get there. And then what resources to find? So you really did do a lot of digging to find all this stuff. And some of the information that you had several years ago is just gone. It's just gone.
Yeah, absolutely. There really is a lot of at least from my perspective, and which I should say our perspective, we like to do research, and so it certainly does seem in a lot of different veins of information that a lot of things that were previously available online are no longer online. So there's a lot of censorship of what you're able to see on the internet, and that certainly makes things harder.
Yeah.
For everybody. I mean, but anyway, let's move on.
Yep.
So, 1955, like I mentioned earlier, Eisenhower has his heart attack in office. They bring in Ancel Keys. He starts promoting the cholesterol hypothesis as the agent responsible for cardiovascular disease, so heart attacks, early deaths, strokes, those types of things, and then Americans are kind of led by the nose down this path of the low-fat diet. So that's what was behind the food pyramid, which, for those of you that remember the food pyramid, the top of the food pyramid was like sugars and candy and that kind of thing. But at the bottom of the food pyramid was something that was almost just as bad, which is, we're supposed to eat 40 to 60% of our diet in processed carbohydrates now. So
Breads,
the
pastas,
breads
rices,
and the pastas and all that kind of stuff. And so that from about 55 until about 1980, people were kind of in limbo, and it was just recommendations, but the food industry didn't really see a whole lot of change. You could probably make an argument for the sugar industry was really pushing a lot of lobbying and propaganda out to encourage people to think along the lines of the low-fat diet, and that sugar was good and that fat was bad. But ultimately, in the 1980s, I'm sure everybody that was alive through that period of time remembers the Snackwell's brand of food, which was, there's this big, huge push in the modern processed food industry to go low-fat. And so everything started going low-fat. And I always like to tell my, my patients or my clients, depending on what setting I'm in, what did people look like before 1980? Now maybe some of the younger generations out there, they don't have anything to compare that to. But for those of us who were alive before 1980, or even maybe some of us who weren't, but maybe were into watching some of the old rerun channels or whatever, and
That would
could
be you,
see,
dear.
yeah, maybe, it could see what people looked like before 1980.
They looked healthy.
Yeah. I mean, they don't. Well, I mean, they don't look like what we do now as a culture or as a society, for sure. So, if that's just one metric, but if you think about that and that one metric, you think, okay, well, why, was there any big change around 1980 that would lead to people looking differently than they did prior to 1980? And the answer to that's yes. I won't go into too much history here, but the tobacco industry took over the processed food industry because they were having their own legal issues, and this was kind of their escape hatch, and they started using their addiction-based business model.
Well, look, when I was in high school in the 80s, the senior boys looked like men. They had hair on their chest, hair on their faces. The girls looked like young ladies. It seems to be a reverse now because we see little girls developing way too fast. When they're 10, they look like they're 13 or 14.
Right.
And these young men stay in this sort of pre-juvenile or this juvenile state.
And testosterone levels are down 50% since then. And, there's all kinds of issues for sure. But ultimately that was kind of a turning point, I think, in our society, certainly around nutrition and how we eat.
Yes.
And I want to give credit for a lot of that to Joan Iflin. Joan Iflin is a PhD and someone who is probably a leading expert on food addiction. So if you're interested in picking up her work, drjoaniflin.com or foodaddictionreset.com is how you can look into her work. And
I'll add the link to all of our social medias where we put this podcast, so you guys can find it on there.
So let's transition into what if any is the recent evidence that statins are safe and effective, or if they're not safe and effective. So here's some studies here, and I just wanted to kind of stick with the last 10 or 15 years.
Okay.
So that we're not looking at old data.
Sure.
I wanted to look at the more recent data, and I'll go ahead and admit before we get into any of this that these are kind of cherry-picked studies, but it just goes to show you that that's why science needs debate. That's why science needs dialogue. I think that most of these people that wrote these papers would be happy to have a debate and have a dialogue with with somebody who did a study that showed that statins were beneficial.
If it's real science,
yeah,
and you're not afraid of the outcome because you're going to follow the truth where it leads, then it must be 100% transparent.
If that's not the case, then science doesn't work, because you have to have that.
Right.
You have to. And for anybody to just say, "Oh, well, the science is settled." Science by design is never settled. And if you can't ask questions, then that's a big, huge red flag to say you're not interested in science. You have an agenda or an ideology that you have to
authoritarian position.
Back up.
Yes.
All right, so let's go back to 2009. There's a paper titled "Lipid Levels in Patients Hospitalized with Coronary Artery Disease." This is from researchers at the Henry Ford Heart and Vascular Institute in Detroit. And they found that lower LDL levels, so LDL, just for you lay people out there, is what they term the bad cholesterol, and HDL is the good cholesterol. Now, I'm not a proponent of those labels. I think that God made us with systems that are supposed to work together and in balance, and there are no good or bad parts of us. They are all parts that are necessary to allow our system and systems to work properly. So, but having said that, they did find that lower HDL levels were associated with worse 3-year survival after ST segment elevation myocardial infarction, which is the most severe type of heart attack. That's the kind of heart attack that you can see on an EKG. And so basically what they found was that if you, had lower LDL levels, and for those of you who aren't aware of this, LDL is the target for statin drugs. So when you take a statin drug, the research shows that they're very effective medications for what they claim to be able to do, which is to lower LDL levels. They lower LDL levels by, in some cases, even greater than 50%, depending on which statin you take and what the dose is and whatnot. But, that's their claim to fame, and they are very effective at doing that. But here's a paper that says maybe that's not a good idea. Maybe it's not a good idea to lower our LDL levels.
Right.
So here's another paper from 2009 titled "Low Admission LDL Cholesterol is Associated with Increased 3-year all-cause mortality in patients with non-ST segment elevation myocardial infarction. So here we have the other type of heart attack. You have the non-ST segment elevation, and this is a study showing that when you have lower LDL levels after a non-ST segment elevation myocardial infarction, you're more likely to die within the next 3 years. And this was not a little bitty study. This was a study involving almost 140,000 people.
Oh, wow.
So this is a large sample size study. In 2010, here's a paper titled Statins and All-Cause Mortality in High-Risk Primary Prevention. So this was by Professor Kausick-Ray and colleagues. They did a meta-analysis of 11 randomized controlled statin clinical trials involving 65,229 participants. So this paper is kind of significant because it was the first one to more accurately separate out the data for primary and secondary prevention. And then they found that the use of statins in primary prevention, so we're talking about someone who hasn't had a stroke or a heart attack, this is primary prevention. They found that the use of statins in that situation does not extend life expectancy. Now, there was also an interesting piece in that paper where the Professor Ray, the author of the paper, actually is still a pretty strong supporter of the use of statins, even though he found this information. And so what you end up finding with a lot of these papers, especially if they're reporting on something that goes against the narrative, is they have to add little bylines in the paper to, I hate to use this term, but I think it's appropriate, to virtue signal the fact that they're still on board with the mainstream narrative, even though their data doesn't really support that.
What would they gain from that?
They don't get ostracized from the scientific body. I mean, if you have an uncomfortable truth to report, then you get ostracized. You get your grants. You don't get your grants. You don't get to participate in the meetings. And especially now, after COVID, that is something that, doctors are getting their license taken away. Pharmacists are getting their license taken away. Psychiatrists and psychologists. I mean, look at Jordan Peterson, the psychological board up in Canada is trying to take his license away because he has uncomfortable opinions that don't fit the mainstream narrative. So that's why. That's why, and that's one of the main reasons that science is broken too, is because it's become this ideological club that if you don't meet the litmus test, so if you don't believe in evolution and you don't, or if you believe in God, even if you do believe in evolution, but you believe in God, then in a lot of cases you can't really be part of that club. So that's huge when you're thinking about what kind of implications does that have on culture. All right, moving along to 2011. There's a paper here that was written by Professors Tor Sherston, Paul Ross, Carl E. Arfers, and Ralph Sundberg, titled "The Cholesterol Hypothesis: Time for the Obituary." And so basically he goes through a lot of the evidence for and against, and the quote from the paper here that I have is, "The cholesterol hypothesis links cholesterol intake and blood levels to cardiovascular disease. It has had enormous impact on healthcare and society during decades, but has little or no scientific backing that is relevant for the human species." And maybe that was a little side note talking about the rabbit experiment. But in any event, he finishes the paper by saying, "Apparently the hypothesis is false and should be buried." Same year, 2011, there was a national study in Sweden from researchers, and I'm going to butcher this name, but researchers at Linköping University looked at statin usage across all but one municipality of Sweden, and found that statins had not provided any benefit, despite a large increase in usage. So the reason why this study is so important is because it is one of the few that have looked retrospectively at if statins actually work in the real world. double-blind, placebo-controlled clinical trials are considered the gold standard in how we look at those things. But what is often overlooked is that the results of those types of clinical trials are a prediction of how the drug will perform in the real world, and it's not a certainty. And I can tell you for sure, as a clinician who has over 20 years of experience in medicine, that the clinical studies that come out with the pharmaceutical companies are very poor predictors of how those products actually work in the real world. And I think that you could see, one of the most glaring, obvious cases of that is if you go back and you look at what we were told about the COVID vaccines in the very beginning. They think they came out and said something in the very beginning while they were still trying to, while they were, still in this study phase for all 9 months or however long it took.
Yeah.
And they were saying, oh, well, these vaccines are 70% effective. And then that wasn't enough for the public. After doing some polls, they came back and said, oh, well, they're 80% effective. And that still wasn't good enough. And then they came back again and said, oh, well, they're 90% effective. And then that for some reason, even though they had just been slow rolling that number up and up and up to get people to buy into it, at 90%, that's when people started to go get their vaccines and all that kind of stuff. Ticket. And we look at things now, and the hallmark, the first thing that I would say on that, and this is kind of a rabbit trail, but, those things aren't vaccines.
Right.
The way that you measure vaccine effectiveness is by showing that blocks transmission and infection. And not only do these vaccines, air quotes, do not do that, but even worse, it's come out in the last 6 months or so that they never even tested the vaccines for transmission.
That's right.
So they had no basis to talk about whether they were effective at all, because their studies only were about antibody responses and did not talk at all about transmission. So, in any event, this particular study in Sweden, basically said there is no evidence that these drugs are beneficial. There's no benefit. And I can, one of the interesting things that I would kind of add to that study is that if you go to the CDC or the FDA and you start looking at some of the things that they say about statin drugs, one of the things that they claim is that there's no scientific evidence that statin drugs are linked with a diagnosis called myopathy. And myopathy is just a doctor term for sore muscles. Mm-hmm. And I can tell you as a clinician who has a history of prescribing statin drugs that there's no possible way that they could claim that is a true statement. Anybody that has prescribed statin drugs knows that they're going to have a significant proportion of their patient population that they prescribe statin drugs to that'll come back and say that they can't take it anymore because their muscles hurt. And so that's just another kind of nail in the coffin here.
Yeah.
The last study from 2012 is one that's near and dear to my heart. The title of this study is The Statin Low Cholesterol Cancer Conundrum. So this one came from Drs. Yuf Rabenskov, Dr. Kilmer McCauley, and Professor Paul J. Ross. They examined the proposed link between low cholesterol, statins, and cancer. So there is an established connection between low cholesterol and cancer. However, they were not able to, solidly point the finger on if statins themselves cause cancer. Mm-hmm. So the effect of statins, the lowering of cholesterol, just the low cholesterol, is enough to increase your cancer risk. Mm-hmm. But they could not say that the statins themselves were carcinogenic, basically. Mm-hmm. But it's definitely, that's interesting, right? How many people do you know that have any kind of idea that low cholesterol increases your cancer risk?
Nobody that I know
Yeah.
knows that. Unless
Almost
they're
nobody.
taught.
And I would probably put most doctors in that category as well.
And almost every elder that I know is on a statin drug.
Yeah. Well, your chances in the United States of being on a statin drug if you're over the age of 60, based on the current recommendation, the statin guidelines, is approaching 100%.
Yeah.
And that was one of the reasons why the European Academy of Cardiology refused the American guidelines several years ago, was because they were like, well, this will just mean that everybody's on statin drugs. Mm-hmm. And they said, nope, we'll come up with our own guidelines. All right, moving up to 2013. There's a paper written by Professor Sharif Sultan and his colleague, Professor Neam Hines, called The Ugly Side of Statins. This paper basically just forms a very concise and powerful systematic critique of the evidence for the widespread use of statins, and also discusses statin adverse effects. So he basically gets into probably some of the real world data, not the pharmaceutical company conflict of interest based studies that come out of that system. He did his own his own review of the data, and it's pretty impressive to go through and read that one. 2015, there's a paper from researchers at Kaohsiung Medical University in Taiwan called Lipid Paradox in Acute Myocardial Infarction, the Association with 30-Day In-Hospital Mortality. So they looked at LDL levels of people admitted to hospitals after a heart attack and found that lower LDL levels were associated with a significantly higher 30-day death rate. So again, let's go back and kind of review this for the layperson. What's the target of statin drugs? LDL. Mm-hmm. What does this paper show? You go in with lower LDL levels, and that's associated with a significantly higher 30-day death rate. So that's, and then you also look at some of the presuppositions of this paper. Well, they had low LDL levels, and why were they in the hospital? For heart attacks. Mm. So, no matter how you look at that paper, it doesn't bode well for the use of statins, in my opinion. And I would imagine the opinions of those researchers. Next paper from 2015 from Japan, Professor Okuyama and Professor Hamazaki, titled Statins Stimulate Atherosclerosis and Heart Failure. And so this is actually some pretty impressive stuff here, because, we're told in this country, and pretty much probably in Japan as well, and any country that's been westernized, that we take statin drugs to avoid heart disease, to avoid calcified plaques, to avoid heart attacks and strokes and those types of outcomes. And so what this paper shows is that there are actually mechanisms in our human, biochemistry, biophysiology, that allow statins to actually cause heart disease. They discuss that statins cause an increase in the amount of calcified plaques in the arteries. They also talk about other ways that statins damage the heart through loss of nutrients like CoQ10, vitamin K2, selenium. Those are things that we use on a pretty regular basis in what we do in order to help to quell vascular inflammation and help thyroid function and endocrine system function and all of that. And so this paper basically describes that, hey, look, when you take a statin drug, you're actually not going to have, or certainly less levels of important things like CoQ10, K2, and selenium. Mm-hmm. You could add magnesium to that list. You could add lots of different vitamins and minerals and nutritional elements to that list, because, and this is something that most people are not aware of, even doctors, most drugs cause nutrition, some level of nutritional deficiencies. Mm-hmm, mm-hmm. The percentage of drugs that the pharmaceutical companies make that deplete magnesium, for instance, probably our most important mineral in the body, probably, from what I've read in the past, most drugs to some degree block the absorption of magnesium. Magnesium is really important in other things. It's important in heart disease. It's important in heart arrhythmias like AFib, which is a very common diagnosis. It's important in seemingly unrelated things like osteoporosis. If you don't have enough magnesium, you can't have balanced minerals. So let's keep going, though. Another paper from 2015. Here's one titled "Towards a Paradigm Shift in Cholesterol Treatment." So this is actually from the same two authors, Okayama and Hamazaki. They published a supplemental of more than 100 pages discussing cholesterol issues. So this is, pretty comprehensive paper here. And of course, the focus was on Japan. However, the data discussed is certainly relevant to any country with widespread statin usage. They discussed the huge amount of data confirming a link between low cholesterol and a shorter life expectancy, and low cholesterol and an increased incidence of various cancers and other serious diseases. So, really interesting paper there. I didn't really have time to go through and read all 100 pages, but it's in the reading library.
I find it interesting that these studies that find that statins are not beneficial are done in other countries. That's where your findings, a vast majority of the studies that are anti-statin drugs, or at least show the con.
Right. Well, that just goes to show you, in my opinion, how corrupt the American scientific and medical establishments are, because it's really difficult to get, grant money and funding to do anything that counters the narrative here, which means that there's no science. It's industry-supported pseudoscientific propaganda is all it is.
Well, all we have to do is look around us. We are the fattest country in the world. We are the unhealthiest.
Actually, I think we're the second.
Are we? What's the first?
You want to take a guess?
No.
It's Australia.
Really?
Yeah, Australia, I think, has beaten us out in obesity, and also in their cancer rate is higher than ours now.
Really?
Yeah. They also have a shortage of freedom, from what I can tell.
Absolutely.
All right, let's keep going. So here is a paper from 2016, lack of an association or an inverse association between cholesterol and mortality in the elderly. Now, this is a really, really great and important paper, because basically, if you just take a second to go through the title, what is an inverse association between LDL cholesterol and mortality? Well, that basically means that mortality goes up if cholesterol goes, or if LDL cholesterol, I got to be specific here. If LDL cholesterol goes down, then if you are above the age of 60, you actually will probably live a shorter period of time. So, and this is not a paper that is in isolation at all. There are many papers out there that show that as we age, we actually need our cholesterol to go up, and that is associated with a decrease in mortality. So we live longer if we have higher cholesterol levels, as we age, and certainly above the age of 60. And then there's a paper from 2018 titled "LDL-C Does Not Cause Cardiovascular Disease: A Comprehensive Review of the Current Literature." So they basically concluded that the cholesterol hypothesis is unable to satisfy any of the Bradford Hill criteria for causality, and support for the cholesterol hypothesis is often based on misleading statistics and to the exclusion of unsuccessful trials and ignoring numerous contradictory observations. So, we already kind of covered that one a little bit. We have data from trials like the big famous Jupiter trial and those types of things that show us that there's relative risk reductions in the use of statins and all of that, but then there's all these conflicts of interest and other things, and so it's really difficult to trust the science. So there are a lot more papers, but I think I will just kind of stick with those. I think that's pretty comprehensive. So right now, what are the current cholesterol guidelines? That's an important thing to know. So right now, And in 2023, in January, they actually came out with some updated guidelines. But, as a general rule, if you go see a conventional cardiologist or general practice physician or somebody along those lines, then you're probably going to get recommended a statin drug if there's a few different criteria here. Number one, if your total cholesterol is over 200. And that's an important figure because we're about to talk about historically what were cholesterol figures. Mm-hmm. So if your total cholesterol is over 200. Another factor might be if you're just a normal person without any health diagnoses, they're going to recommend that your LDL be less than 100. So if your LDL is over 100, then that would be a factor to go with prescribing a statin drug. However, if you're diabetic, doesn't matter, type 1, type 2, 1.5, 3, there's all kinds of different diabetes now. But if you're a diabetic in any way and your doctor is aware of that, then now that means that your recommendation on LDL is even less, that you can't be above 70. Now think about that for a second. LDL below 70, especially in light of all those papers that we talked about how, as we age, as the LDL goes down, we have a decrease in life expectancy. Next one is if you're between the ages of 40 and 75, if you have one or more cardiovascular disease risk factors. So if you have hyperlipidemia, that counts as one. So total cholesterol, above 200 or LDL above 100 or 70, depending on what which category you fit into, then that is a cardiovascular disease risk factor according to the conventional guidelines. If you have diabetes, of course, we talked about that a little bit with a different LDL recommendation. If you have hypertension, so if your blood pressure is above 120/90 and your doctor's trying to get you, or if you've been on blood pressure medicine for a while, that is a cardiovascular risk factor. Of course, we all know smoking is a risk factor. So if you have any of those and an estimated 10-year cardiovascular disease risk of 7.5 or more, then you'll be recommended to be on a statin drug. So when you really get down to it, if you're between the ages of 40 and 75 and you live in this country, guess how many people, or what percentage of the people are going to have dyslipidemia or hypertension? We can just stop with those two. And that's probably going to be most people based on the current guidelines. Mm-hmm. So, hey, now we can get people started on statins when they're 40. And, look at that great primary risk prevention. We can keep these people with super low cholesterol their entire lives, and maybe they won't live so long.
Yeah, maybe they'll slide right into dementia.
Well, one of the things I want to make really clear is even the doctors that are out there promoting statin drugs, I really do feel like the majority of them are, good people, well-meaning. I'm not trying to demonize anybody here. I just think that we need to take our power back as individuals and not just rely on people that have been indoctrinated in a system that has just a huge amount of corruption in it, that it's important that we actually know some of these things for ourselves. And everybody that's listening to this podcast right now is smart enough to, turn off Facebook for an hour or two every once in a while and start looking at data behind things that are really important to you. Because, think about this. How many people that are listening right now have been taking a statin drug for 5, 10, 20, 30 years at this point in time, just based on, that all goes back to this cholesterol hypothesis that there's really no convincing evidence behind.
Well, I want to bring up something really quickly to that point, is that people don't really get informed consent anymore.
Right.
Doctors are so overwhelmed that they do the patient shuffle, in and out, in and out, in and out.
Yeah, they don't have time to do anything except write a prescription.
And it is, before I knew anything really about health and wellness, I would have done what a doctor told me to do without even thinking twice about it. Mm-hmm. I was very mindless about going to the doctor and just doing whatever they said.
Well, that's because you were a good patient.
Yeah.
And you were trained to just do what your authority figure told you to do.
Right.
and that everything would be fine, and that you had no input into it. It
Right.
had nothing to do with your diet or your
And
lifestyle.
I didn't believe that I was
you
smart
just needed
enough.
you just need to take this pill.
Right. And I didn't believe that I was smart enough to understand
Yeah.
what I needed to know. But now, in fact, I know that that's not the case. And again, there's something that I want to bring up is that we actually have a client who, after going through his medical records, discovered that he had been given 2 COVID vaccinations without his consent that he knows of, but because there probably was something lost in translation, and it would have been easy enough for the doctor or the nurse to say, hey, it's time for your vaccination, and for this client to say, okay, and not really even understand what was being given to them.
Well,
lack of informed consent, lack of advocating for yourself.
Well, that right there, I think, hey, that's our. I think we ought to do that topic next week. Informed consent.
I agree with that.
Basically what we're going through here with the statins and cholesterol, podcast here today, if that doesn't make you want to make sure that you get informed consent, then I don't know what will.
Right. And this person did not want the vaccination, but now they've had two doses even without their own knowledge, even though they probably said okay, not realizing what they were saying okay to.
Right.
Which is the patient
shuffle.
Well,
and that's the thing, we are bound, or at least in theory in this country, as medical providers, or clinicians, we're bound by the Hippocratic Oath, and we're also bound by legally the principle of informed consent.
Yes.
And that's been true ever since the Nuremberg Code came out of the Nuremberg trials, following all of the atrocities that came out of World War II in Germany. So let's do informed consent next week.
I agree.
Yeah, that's super important to us. So let's keep going here. So those are the current guidelines for when your doctor's likely to recommend that you start on statin therapy to reduce your cholesterol. What is the evidence that those guidelines are not consistent with health? Well, I went through all the studies before. I think that those are relatively self-explanatory. But as I mentioned earlier, I was able to find a study. It was not easy, and if I didn't have my network of other doctors and clinicians to work with, I probably wouldn't have had access to it.
Right.
But I was able to gain access to this particular study by Dr. Kornerup in 1950, and it looked at the total cholesterol levels along with some other lipids and other things. But all I was interested in really was the total cholesterol levels of 117 perfectly healthy adults and 95 perfectly healthy children. These were people that were enrolled in the study without any known health issues or any family history of significant health issues, but most importantly, xanthelasma, which, for those of you that aren't familiar with that term, which is probably just about everybody, xanthelasmas are those little skin tags that you might see in some people under their eyes, in the where you get bags under your eyes. Those people get little skin tags and moles in that area. Those are called xanthelasmas, and those are caused by very high cholesterol levels. So none of these people enrolled in the study could have that condition, nor could they have hereditary hyperlipidemia, which was known about back in 1950, nor could they have any personal history or even family history of heart disease. So, and keep in mind, this is in 1950. Mm-hmm. So the important thing to consider in this is that this was largely before the adoption of, processed foods. Mm-hmm. Now that's not 100% true, because there was, industrialized bread, the Mrs. Baird's and that kind of stuff. But compared to today, we're on virgin ground.
Right,
They ate a completely different, much more traditional diet in those days than we do now. I think everybody could agree with that.
Well, and their health showed it. My great-grandfather lived to be in his late 80s. He did have heart disease, but my great-grandmother, who ate fat every day of her life, cooked eggs and bacon in bacon grease from the previous day, biscuits.
Yeah.
The woman lived to be 104. She never had a cavity. She was cognizant until the day that she died.
And ornery.
And she was ornery.
And could play that piano.
Boy, she could. She was something else.
Yeah. No, I mean, she's, certainly a piece of evidence.
Yeah.
So basically what I did was I went through this study and I built myself a little Excel spreadsheet here. And I wanted to see what the average cholesterol levels were in men and women and boys and girls, and then I just went through all the different categories, averaged them all together and everything. Now, these are just averages, so these numbers may not seem super, crazy high, but keep in mind these are averages. So if I remember correctly, the low out of those, what would that be?
17.
Well, 117 healthy adults and 95 healthy children.
Yeah.
So, the average of everyone's cholesterol, 214.
Mm-hmm.
So, by that, if you were the average person in 1950 and you came in a time machine to 2023, guess what? You get to be on a statin drug.
Yeah.
So let's go into the different categories. If you're looking at men, the adult men average was actually the same number. It was 214. The average cholesterol among women in the study was 229. Among the boys, it was actually 201, and among girls, it was 218. The average total cholesterol among adults was 219. The average total cholesterol among children was 209, and then back to the average total cholesterol for all of the participants was again 214. So we can kind of ascertain by that in a relatively healthy population that ate a diet much more healthy than what we eat today, that in every category, the normal cholesterol level for people is above 200. And so, like I was going to mention this before, and I kind of got sidetracked, and we just kept moving on. But in that data set, the lowest cholesterol was 132. And then the highest cholesterol that I saw in there was 320. So there's a big range of cholesterol. And so we're just talking about the averages here. But, it was apparent by just looking at the data sets when I was going through it that the average cholesterol was going to be above 200. Of course, I did my due diligence and put everything in a spreadsheet and did the calculations and whatnot. But
you did. You worked hard at this research to make sure that you crossed every T and dotted every I. We want to be accurate. We want to be transparent.
Yeah,
we want to be
absolutely
truthful about the information that we give.
Well, so, some of the takeaways here. Adults have higher total cholesterol than children. That's consistent with the data from some of the studies I mentioned earlier, saying that as we age, higher cholesterol levels are actually protective for us. There were a couple of studies I mentioned that had that message. Females do have a higher total cholesterol level compared to males. The total cholesterol averages among healthy people eating a relatively healthy diet were all above the current guidelines for initiation of statin therapy. And I mean, if you just take a second and think about that, here we are dealing with people, and I think that the oldest person in this study was in their 90s, I think 96, if I remember correctly. So this is, basically from newborns all the way up to 96. And across the board, we were above 200. So if that's not an indication that something wrong with the current guidelines, I mean, hey, look, if you're a pharmaceutical company out there and you're like, hey, if we can come up with a good reason for people who have a cholesterol above 200 to take these drugs, then we'll make a bunch of money. As a matter of fact, just off the top of my head, I read a paper yesterday that was talking about how the pharmaceutical industry has made over $1 trillion only off of statin, or I shouldn't say statins, but on cholesterol lowering drugs. They've
My
made over $1
goodness.
trillion collectively. I don't think we could even fathom that kind of money. What else do we got here? Total cholesterol averages among healthy people. Oh, that's what I just covered. And then finally, combined with the above studies showing limited to no benefit and also considering the significant harms that are associated clinically with statin use, they really, in my opinion, should be used very sparingly and only in certain demographics and only after a really good hard push for informed consent. That's my opinion.
And I do want you to get into the cons of, in some cases, like you said, it would be a pro. But I do want you to get into the cons of what can happen.
Well, so now, and this is another thing that I was really surprised to see on I can't remember I think it was the CDC webpage. But they are basically saying that based on the studies that they've reviewed, there's no evidence of myopathy, which was what we covered before. There was no evidence of association with elevated liver enzymes, which would be a marker of liver damage. Mm-hmm. There was no evidence of what was one of the other ones. There was no evidence of their association with the development of diabetes. And there was no evidence of the association between statin use and reduced cognitive function. So when you talk about cognitive function, we're just talking about how your brain works. We're talking about dementia and those types of things. So I can tell you that I have read papers that counter every single one of those claims. Mm-hmm. Multiple papers that that do find a positive correlation. Now, I'm not necessarily saying that that statin drugs cause that, because the burden of proof there is much higher than correlation. But correlation is enough to say, hey, there's not a smoking gun, but maybe we need to look into this a little bit more. So statin drugs are correlated in several scientific papers. That probably have less conflicts of interest, if I were going to guess.
Yeah.
With the development of cognitive disease, with the with the development of elevated liver enzymes, with the development of myopathy, with the development of diabetes. In fact, there's one paper that I can quote off the top of my head that said that among people that take statin drugs, they are 15% more likely to get a diagnosis of type 2 diabetes. And only because they're taking the statin drug. So that one was a causative finding in that paper. But those are the significant side effects that taking statin drugs have been correlated with. And I could tell you as a clinician that I have seen those things happen to people that take statin drugs. I've watched it happen with my own eyes. And so when you go to the CDC website and they say, oh, there's no studies that we've reviewed have seen that. Well, they're obviously not talking to clinicians, because every clinician that I've had that conversation with says, oh yeah, I see that too. And they're also not looking at all of the data. They're cherry picking their data. So they're only looking at studies, that in my opinion probably have a conflict of interest, and that have statistical fuzzy math going on.
I want to ask you a question. I'm curious about your thoughts on this. What was it like for you when you were really engaged in the standard of care, in your practice, and you were handing out statins like they were candy, and then you started to do the research? What was that like for you to see what was really happening here and why it was really happening?
Well, the honest truth about me, and of course, here I am. We've got our company, Worldview Wellness, and we're focused on the truth and all of that. The truth is, in my life, that was probably the area, because of my education, where I was the most indoctrinated. And so, I knew about the financial systems, I knew about the education systems, I knew about, the corruption in foreign policy, and in the nonprofit organizations and the philanthropic organizations and all of those. I was willing to accept all of that before I was willing to accept that medicine was corrupted.
That's how strong.
So that was the last, that was the last thing I kind of peeled back and was willing to say, okay, well, so how I got educated was wrong. Not that everything in it was wrong. I mean, sure. I learned a lot, and that I still use today. But yeah, at the end of the day, that was the last thing that I came to. And it was really difficult for me to start, there's a lot of cognitive dissonance I dealt with.
It was actually like a gut punch for you.
Oh, yeah.
I remember when you started going through your wake up with medicine, and it was really brutal for you. It broke your heart. It broke your heart.
Well, before we finish up, I want to go through some statistics that I think are really important. And so this is something that is broadly applicable to just about any drug, for sure any drug. And these are statistical terms that everybody, especially everybody that's taken a drug, needs to know, and needs to know specifically about the drugs that they take.
Okay.
So the terms that I'd like to introduce, number one is relative risk. Number two is absolute risk. And then number three is number needed to treat, or NNT. And so why is this important? Well, let's talk about that. Relative risk is a very, very, very commonly used term when you're looking at pharmaceutical company studies. And the reason is because you can really hide a lot behind relative risk and relative risk reductions. So let's just say, for instance, that you have and I'm not going to say anything specifically, we're just going to say hypothetically, there's a disease out there that 2% of the population gets, right? And the disease is maybe not all that severe. Maybe you get over it on your own or whatever. None of that's really important. But 2% of the population gets it. So if you have a drug and you can do a study and show that when, if you have 100% of the population take this drug, well, now instead of 2% of the population getting this particular illness, now only 0.5% of the population gets that illness. Well, you are just able to show that drug has a 75% relative risk reduction. And so on paper, that looks really good. Oh, dang, 75% risk reduction. That's wonderful. But that number fails to mention that, well, you had a 2% chance of getting the disease in the first place. So your chances in the first place were not very high at all. And if you then compare that to what is the absolute risk reduction, you say, okay, well, that's easy. Absolute risk reduction is super easy. You take 2%, you subtract, 0.5. So really what you get, the absolute risk reduction is only 1.5%. So we shouldn't be surprised at all to know that the pharmaceutical companies like to use relative risk reduction numbers. But the important thing to really know from the standpoint of if you're a physician or any kind of clinician, or if you're a patient that's being asked to take a drug or recommended to take a drug, well, what is the relative risk reduction? But what is the absolute risk reduction too? Because the absolute risk reduction of 1.5% basically is like, well, that drug is not really, can't provide that much of a benefit.
Right.
And that is exactly what we find the pharmaceutical companies doing with statin drugs. So this was just last year. There was a meta-analysis study, and this was actually published in JAMA, believe it or not, showing that the currently advertised relative risk reduction for statin use, they're able to reduce all-cause mortality by 9%. The relative risk reduction for heart attacks, they're able to reduce those by 29%. And then the relative risk reduction for stroke was decreased by 14%. However, the absolute risk reduction, so this is like actually how it plays out in real life. So if you're just Joe Schmo, you go to the doctor, you get on your statin drug. That means that your chances of having a reduced, or your reduced chances for having a heart attack are not 20, all-cause mortality are not 9%. Your actual absolute risk reduction for all-cause mortality is only 0.8%, so less than 1%. The absolute risk reduction for heart attack is not 29%, which is the relative risk. It's actually 1.3%. And then for stroke, that's the best one. It's not 14% reduction for stroke. The absolute risk reduction for stroke is only 0.4%, so less than half of a percent. And then the final number that I want to give you guys before we close it out is the number needed to treat. So that is a statistical calculation that's defined as the number of patients that are needed to take a drug to prevent one adverse outcome. So the number needed to prevent one death, the number needed to treat, is 83. So, and I would probably wager to say that the majority of people that are out there taking statin drugs take it because they don't want to die. So that would be, all-cause mortality. That's the most important figure when you're talking about drugs. You're only going to get that benefit if you're the lucky 83rd person to get that drug. And there's no way to determine whether you're going to be that 83rd person or who else. But the number needed to treat to prevent one death is 83 people. The number needed to treat to prevent one heart attack, well, that's a little bit better, but it's still 39. So that means that you have to write 39 prescriptions to prevent one heart attack. That means that the other 38 people, it's not going to do that for them. And then for stroke, that's the worst number. For stroke, the number needed to treat to prevent one stroke is 125. So that means 124 people are going to risk all of the potential side effects of those statin drugs with no benefit.
To possibly prevent one stroke.
Yeah. So, maybe your main concern is not death or stroke. Maybe it's heart attack. And that puts you in the best category that they have here. The number needed to treat is still 1 in 39. So that means that you're still infinitely more likely to be the person that it doesn't help than the person that it helps.
Right. And you'll never know.
And so when we're talking about, certainly cholesterol drugs, but drugs in general, those are all really, really important things to consider, especially when you're talking about looking at the studies and the statistics. So you want to know, not just what the relative risk reduction is, but also the absolute risk reduction. You also want to know what the number needed to treat is. And if you kind of put together that kind of a package of analysis and are able to look at that yourself, then that'll give you a good idea of whether what you're being asked to take, whether that's a drug or a vaccine or anything else, kind of give you a good framework for how to make that informed decision.
This is one thing that I absolutely love about what we do, is that we give true informed consent and we educate. And that's why you named the business Worldview Wellness, because depending on what you are willing to seek out, what you are willing to research, how much time you're willing to put into that is going to guide your worldview. Yeah, absolutely. And your world, and I would even kind of flip that on its head. Your worldview is going to be how, that lens of perception that you see the world is going to be, kind of the rules, and at least in your own consciousness of how it is that you're going to make these decisions. Well, so we love to educate our clients. We do a lot of educating just like this, one-on-one with our clients. We do like to give informed consent, which we will be talking about in our next podcast next Friday. And we give informed consent. We have many wellness clients. We have many cancering clients. We have many clients who have, metabolic dysfunctions that we address.
Yeah, and you name it.
You name it. We see it. But when these clients of ours are undertaking other modalities, for instance, if we have a cancering client who has chosen to do chemo or radiation or things like that, we will sit down with them and go over their chemotherapy plan, and we will talk about, and we will give them informed consent. And more often than not, they have not gotten it from their doctor. They have no idea what they're venturing into. And
no idea what the plan forward is, if this thing fails,
or if it's chemo forever until the conclusion is reached.
We've had lots of people that are on what they would consider, palliative chemo. Mm-hmm. So at that point in time, if you're on palliative chemo, then they're not trying to cure you anymore.
There's no end in sight for
They're
it.
just, basically doing everything that they can to extend your life. But at the same time, the drugs that they're using is also, typically greatly reducing your quality of life.
Yeah.
And of course, there's a wide, there are big differences in how oncologists treat their patients.
Right.
We've heard of, good oncologists that are really supportive of,
Mm-hmm.
what we do and the supplements and the dietary recommendations and really focusing on nutrition and overall well-being. And then we have run into other oncologists, unfortunately, that, that basically tell them that all that's a bunch of hooey and they should just take the chemo and the radiation and,
Which,
and that's unfortunate.
If we have a client who chooses to venture into those therapies, we always talk about the pros and the cons of it. We give them informed consent. And if that's what they choose to do, if that's what brings them peace, then we're going to support that journey and we're going to do...
Well, and I like to go through also, whenever we do our onboard visits with a cancer client, I'd like to go through their chemotherapy regimen or whatever is being recommended and say, hey, look, this is, in your situation, this is not a bad idea. This is an indicated therapy.
Yeah.
And I might even further that and say, this is probably what I would do.
Yeah.
Or this is what I would encourage my family member to do. Mm-hmm. But at the end of the day, we always tell people, you're the captain of your ship. You get to drive the boat.
That's
and, right. Even if it's one of my recommendations, you do not have to do it.
Right.
If you don't have peace about it, and you want to, even if you wanted to pay a bunch of money for us to do a really in-depth workup and you want to do none of the plan, well, you are entitled to do that.
Right.
I mean, it's your money, it's your life. You get to do what you want to do. And that's where you come in a lot with the advocacy and teaching people how to, advocate for themselves in addition to you being their advocate as well. Because if you can't be your own advocate, then, that leads to poor prognosis.
It really does. And informed consent really does help our clients.
Yeah.
It helps them be able to advocate for themselves, which is really difficult in today's world of medicine.
Yeah. Especially now.
Yeah.
Especially since COVID. Everybody's so burnt out in the medical industry and they're underpaid and overworked and I mean, I was telling you the other day that although I've put some time in the emergency rooms, I couldn't imagine
being in there now.
It would just be chaos.
Well, I think, do you have anything else to add to this?
No, I think that pretty much covers it.
What great information. I really appreciate
we
all
could
the
spend
research.
another 40 hours covering all of the details, but I think this gives a pretty good 40,000 foot window view of kind of my worldview.
That's right. Man, you did so much research on this. I really appreciate it. And I learned a lot today.
Well, that's the goal.
And through your last week's effort of research. I really appreciate it.
That's what we do.
That's right. So we want to thank you for joining us today. This is Worldview Wellness Health Matters, episode 5. And
next week will be 6.
Next week will be 6. And we'll be talking.
We're on a roll.
That's right. We're doing it. And next week we'll be talking about informed consent. Please join us. You guys have a blessed week. Be good to yourself because your health matters.